So I just would like to welcome you all to the SGS COVAX talk, which is an initiative, a graduate student initiative to discuss the impact of COVID-19 on communities and understand how as students we can get involved and be engaged in public outreach. I'd like to start the event by acknowledging the land, and I would like to acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, and the Wendat people. And this land is now the home to many diverse First Nation, Inuit, and Métis people. I would like to start by introducing our panelists. We had the pleasure of having Dr. Michelle Murti, and Dr. Michelle Murti is the medical director at Public Health Ontario. And she is a specialist in family medicine and public health and preventative medicine at the University of Toronto. And she's an assistant professor at the Dan Alena School of Public Health at the University of Toronto. Welcome, Dr. Murti. Next, we have Dr. Gabriela Capurro. And Dr. Gabriela is a postdoctoral fellow in the Department of Community Health Sciences at the University of Manitoba. Her research focuses on health and risk communication, science communication, lived experiences of risks, and discourses of health and illness. She has published studies on coverage of outbreaks of vaccine and vaccine hesitancy topics. Next, we have Mr. Mohan, and Mr. Mohan is the director of the Newcomer program and youth wellness at the WoodGreen Community Service. WoodGreen Community Service. Mr. Das has significant experience in nonprofit governance and have served as the chair of the board for the Canadian Centre for Victims of Torture. He's also committed to working on issues affecting visible minorities in communities and for newcomers. Welcome, Mr. Das. So with that, I would like to start by maybe going around where asking each of the panelists to tell us more about their role and what they do in their daily role and job. So first to you, Dr. Murti, and welcome.
Thank you so much for inviting me to be here. It's my pleasure to join the session and really great to learn about the ongoing COVID talks that you're hosting. So congratulations for finding time, and I'm sure everybody's busy schedules to continue to keep up these talks. So I'm the medical director in what's called the Health Protection Portfolio at Public Health Ontario. So my non-COVID job is normally in infectious disease. So I specialize in influenza and other emerging respiratory diseases, as well as bloodborne infections and STIs. So our role at Public Health Ontario is to provide scientific and technical advice to a variety of stakeholders, including the Ministry of Health, the Office of the Chief Medical Officer of Health, as well as local public health units and other health system stakeholders. So we do the provincial surveillance for all communicable disease, reportable communicable diseases in the province. And during the pandemic, COVID role has really been in providing the public health guidance for case contact and outbreak management for COVID-19 in the province. I'm also on several of the provincial committees, so the expert testing panel committee. I'm nationally on the National Advisory Committee for Influenza, one of the subcommittees on infectious diseases of high consequence that's been advising on the advisory immunization statements.
Wonderful. Welcome. Gabriela?
Yes, thank you so much for having me. I think these are great. And I also congratulate you for organizing this. And I am a postdoctoral fellow at the University of Manitoba in the Department of Community Health Sciences. And my research is mostly focused right now on COVID-19. I am part of a pan-Canadian study funded by CIHR, and we're looking at risk communication of COVID-19, many aspects, including, of course, vaccination, perceptions of risk, vaccine hesitancy, compliance with guidelines, and so on. And previously, I have worked with vaccine hesitancy from a communication perspective, as well as media discourses of communicable diseases and other types of diseases and health risks like antimicrobial resistance, which are different but have their own problems. But right now it's all COVID-19. So I'm very happy to be here and share some of that.
We are certainly delighted to have you here. Mr. Mohan?
Hi, thanks for inviting me. Really happy to be here with you guys today. I have a special connection to UFT. I did work there back early in 2000 for about 5-6 years with the Faculty of Engineering, the downtown campus. So UFT is always a special place for me. Anyway, my current role is as the Director of Newcomer and Youth Wellness at WoodGreen Community Services. WoodGreen is one of Toronto's largest community service providers. We serve annually close to about 40,000 clients, helping them with settlement issues, housing, mental health, senior services, child care, language classes, employment, financial empowerment.
Oh, we lost him. Hi. I think we lost you for a minute.
Okay, I'm back on now. Okay.
Yeah.
Sorry about that. So, so WoodGreen is a large organization, but my role here is pretty much to manage all programs and services that engage with newcomers. And when I say newcomers, it includes skilled class immigrants, family class immigrants, refugees, refugee claimants, international students, and work permit holders. So any service that engages with that is provided towards any of this group of people falls under my my portfolio here. But I'm here to talk more about my particular experience managing a program called interprofessional care, where we have settlement workers and social workers work in family health clinics in partnership with physicians and registered nurses, mostly working in addressing the social determinant aspects of health, ensuring that a patient who walks into the clinic is also connected to, let's say, income security, food stability, housing, employment. So they make those connections for patients who are walking into that clinic based on the physician's recommendation. And this has led to our work in terms of the pandemic response in Taylor Massey and Oak Ridge neighborhoods in Toronto. And we have been working within the pandemic response since April of last year in these two communities. So anything that I share today is based on my experience working with newcomers in these two communities. And I'm really happy to be here.
Thank you, and we are delighted to have you all here, and we really appreciate your breadth of experience and time. It's really an honor for us to have you, all of you here. So without further ado, let's get started into the questions, and we have the questions by the team and also by some audiences that we look forward to. Please, if you have any questions, to post it in the Q&A, and we will address it to the panelists shortly. So please keep your questions going into the Q&A. So I would have a few questions that I would like to start with, and I would direct my question to you, Michelle, is to talk to us about, like, maybe give us a perspective of who reviews and approves the safety of vaccines at the government, and if you're aware of the process, like how does it move from being approved by Health Canada to the government and the public health units?
Sure, yeah. I mean, we're kind of in an exceptional time of vaccine production and approval. So I think the pace of which that we're getting through vaccines, which is just an incredible process and achievements that we have in terms of curbing this pandemic. I think we want to make sure that we say that the process that we're still using by which vaccines are being approved is still the same process that we would normally use for any other vaccine at a regular time. That just the sort of speed by which some of these applications are being reviewed is obviously very different now, because we want to get people vaccines as soon as possible. So in terms of clinical development and trials, so once a company has an idea of how a vaccine that works, it goes through the stages of of the animal studies, and then phase 1, phase 2, and phase 3 clinical trials. So phase 1, 2, 3 is sort of an ever expanding size of people who are involved in those clinical trials. And then once we get to that phase 3 trial, then they would put in their application to the regulated authority. So every country has their own designated regulator for approval of these. And so for Canada, we have Health Canada as the approver, the regulator for saying yes. And they do a very thorough assessment so that the vaccine company has to show all of the results from their trial data. If Health Canada has any questions, they can go back and ask the company to submit more information in terms of the safety, the efficacy of their products and the results of their trials. So that's all reviewed by Health Canada. And so Health Canada then does the kind of approval to say, yes, this is an approved use. And really because of some of the uses and the way it's evolving, a lot of these are kind of under more of an exceptional use type approval. So really kind of a limited scope of approval compared to what, a full vaccine program might have. But so they have the ability to update those approvals over time or to change the approvals really quickly if there's new information about safety or efficacy of the vaccine. So that Health Canada, once it's approved by Health Canada, then that's designated to be is able to be used within the Canadian context. But then we kind of move into what we call sort of phase 4 trials. Is now we're starting to use it in the population. So there's an ongoing safety process there. So in terms of Health Canada approving the ability to use, the other kind of National Advisory Committee on Immunization is the national group that helps advise how to use them. So the regulator of Health Canada says, yes, they're safe to use, and these are the indications that you can use it for. Then the National Advisory Committee would help provide additional information to say, what, yes, you can use it in this group, but here's sort of the best way to use it, and then provide recommendations, to say, should it be used in pregnancy? Should it be used for immunocompromised individuals? What's the best interval between first dose and second dose to try to provide those recommendations of how we're using them? And then really it goes down to the provinces who get the vaccines and then also form their own recommendations for how they're going to use it within their own province. So that's kind of the multi-stage kind of way of getting approved, guidance of how to use it, and then how it's actually rolled out at that provincial level. And we're even seeing now kind of in the Ontario context, even sometimes, even further at the more local level, sometimes tailoring of how they're being used. And then really kind of gets down to that, that patient provider level is to say, once you're actually getting that vaccine, so a lot of the discussion that might happen between a healthcare provider and their patient as to say, how do we tell you specifically, given your individual level context, what's the best vaccine option for you?
That's super impressive. And I think, one of the things is it feels like an unknown knowing exactly what's happening behind the scene. And so this is really super interesting for us. And I imagine, I think the team dynamics even of working through such a COVID-19 period has completely changed to, from things that takes long periods of approval to things that are just working 24/7 to kind of address a problem or, work on a process. So I feel like it's really impressive how much work is put in by teams and changes during COVID-19. So I'll turn to you, Gabriela, and my question to you is, you study a lot about communities, and I was wondering, how do cultural diversity and language barriers impact vaccine hesitancy, if at all, especially in cosmopolitan cities like Toronto or New York or other of the big cities, and how do we see differences in terms of rates of vaccination?
Yes, that's a very interesting question, actually. And there is this perception that maybe anti-vaccination or vaccine hesitant feelings are stronger in bigger cities because there's more diverse communities. However, we need to take into account that when it comes to vaccination and to promoting vaccination, there's got to be a strategy that really takes into account the demographics of the whole population that you're trying to address. And this is not only whether they're immigrant or they come from a different cultural background, different language, but also things like age and even in which part of the city they're living. So when we talk about risk communication in the case of vaccines, we want to make sure that we have a communication strategy that really reaches all these different populations, and particularly underserved populations. Usually it is racial minorities, immigrants, the ones who are most vulnerable already to disease. So these are specific communities that we want to target. And this might mean, for example, translating the message to different audiences for different languages, and also crafting messages that address their specific concerns, whether they be cultural or different values or different religious beliefs. But on the other hand, what we're seeing is that in less diverse contexts, smaller cities and so on, there's also a lot of vaccine, I shouldn't say a lot, but there is also like the same proportion of hesitancy that can be driven more by lifestyle preferences or beliefs. As there is an issue of addressing diversity that is important, but not kind of diverse places, for sure.
That's super interesting. So on that note, Mohan, like you've been working with communities and been in communities, to what extent has vaccine hesitancy and like misinformation about COVID-19 been circulating in newcomers and immigrant communities, and how has the community been managing those misinformations or hesitancy?
Sure. So like I said at the very beginning, all of my opinion and insight is based on my particular work in two neighborhoods in Toronto, the Taylor Massey neighborhood and Oak Ridge, where close to about 60 in one and 65% in the other is made up of newcomer population. So these are really highly newcomer visible minority population communities. Okay. So when we talk about vaccine hesitancy, I'm a little uncomfortable using the word vaccine hesitancy in these two communities, because what we're seeing more of is vaccine complacency rather than vaccine hesitancy. Okay, but this could be because of many reasons, at least in these two communities, because right as soon as the pandemic started here and it was declared as a pandemic, as early as April of last year, we set up a community response team in these communities, which was made up of community residents. And before I go into that, you need to understand these two communities. These are really high-rise communities, or what we call as vertical neighborhoods, where in Taylor Massey, in a 1 square kilometer, more than 13,000 people live. But that's the official estimate based on what the official count of the apartment units that are there. So how many 2-bedroom, how many single bedroom, how many studio apartments are there? And it's based on the legal limit for these units. But as you know, in communities such as this, where there's more poverty, there's more housing challenges, some of these 2-bedroom units could have anywhere between 6 to 8 people living in that. A single bedroom unit could have anywhere between 3 to 4 people living in that. So the official count is 12,000 people, but it is much more than that. So that's the context of this neighborhood. So what we did was we set up a community response team as early as April and May of last year. And these were made up of volunteers from residents from each of these high-rise buildings. Some of these buildings are condos. So from the condominium, we had representatives from the condominium board as part of the community response team. We had superintendents, building supervisors on the community response team. So this community response team has been working since April of last year in terms of health promotion and awareness. So promoting the need for getting tested, promoting the need for social distancing, hand hygiene, masking, the use of PPE. So they have been working with this community since April of last year. So that's why maybe we are not seeing a lot of vaccine hesitancy, but rather some vaccine complacency. But like I said, this could be different for another newcomer community in Toronto itself, where probably the same level of health promotion and awareness work has not been done, right? In terms of examples of what is the impact of vaccine hesitancy or complacency here, has been that we set up the first community-based testing site in the whole province in Crescent Town. So outside of hospitals and community health centers where testing happened, this was the first community-based testing site that was set up in the whole province. So Michael Garron Hospital is the one that we partner with, and we worked with them in terms of doing all of the pandemic response work. So when we set up the testing site there, we realized that after the first few days that we were not seeing a great uptake for the testing. So what we did was we worked with the local doctor, the family physician who's been in that community for more than 2 decades. So we created a video. This doctor would speak Bangla or Bengali, which is the predominant community in that neighborhood. So we recorded a video of this doctor talking about the importance of getting tested. And we knew that people were not getting tested because if they tested positive, they felt that they will not be able to work. Because a lot of them are not in work where they had the benefit of paid sick leave. They were all in precarious employment. A lot of them work in the underground economy where they were paid in cash. I mean, if they don't show up for work, they don't get paid, right? So we made a video of the doctor explaining the testing process, the importance of getting tested, but most importantly, the support systems that they have in case they get tested positive. So we created this video, and the community ambassadors that we had as part of the community response team, they shared this on WhatsApp groups. So the buildings had WhatsApp groups, right? So the residents had WhatsApp groups. So they shared it in their own buildings and within their networks. And that's how we started getting people to come in and get tested. Also, we realized that these are people who can take time off to get tested. They can get paid time off to get tested because they were in such kind of employment. So we started running the testing clinic from 3 in the afternoon till about 9 in the evening, so that people who could come after work and get tested. And then we could see that the testing increased significantly. When it came to vaccination, we have run close to about 12 pop-up clinics in partnership with Michael Garren. We have vaccinated more than 12,500 as of yesterday. And in all of these pop-up clinics, at the end of the day, we had to turn people back because we didn't have enough doses to give. And some of these days we were giving out more than 2,000 doses. We still had to turn people back. So my question is, where is the hesitancy here? When people are coming in and lining up for like 4 hours and 5 hours to get their vaccine shot, where is the question of hesitancy? So I think it's more vaccine complacency than hesitancy.
I want to thank you so much for this point, because I think what this has highlighted is there is prejudice and assumptions in general population that, you know, like diverse or marginalized groups are less likely to be compliant with vaccines and approach vaccine first. And I think it's important to be reflective and think exactly what the data is showing, and recognize that, you know, like because like it's not being so people are not being hesitant or not compliant because of they are not believing in the vaccine, but there are more of inequities that are affecting their ability to approach and comply with vaccine. So I appreciate so much sharing those experiences. Michelle, let me turn on to you and ask you the questions that, you know, like within your, what are some of the challenges that have been like what Mr. Mohan Das was talking about? What have been some of the concerns from in Toronto's communities that and challenges that have been raised to your health units regarding outbreaks and vaccination, and how did you handle that?
Yeah, I mean, I really appreciate what Mohan was saying. I think that there's, you know, if you build it, it will come, and making it available is got to be one of the first steps that we're trying to do. You know, some of the challenges that we're seeing and hearing back from the health units are, you know, people who may not have a legal status in Canada, and so are unwilling to come forward because they're being worried about having to provide their information. So, you know, I know Toronto Public Health has done some specific pop-up clinics that are like, you know, no questions asked, like they're going to put your name as ABC, your address, 123, and that's it, so that you can get your vaccine, and we're making sure we're giving it in an accessible way to those individuals. You know, I think getting like the awareness of like how to even reach the people, because they're trying not to be found. And so how do we get that information? So I think, you know, leveraging groups and community activism like what Mohan's describing is so critical to that, because we have to get it to the people that they're going to trust to be able to come forward and be aware. Like, obviously these are not the regular pop-up clinics, like to know this. So how do we get the people to those sites so that can be done in that way? I think one of the ongoing challenges we have with that, though, is to say, if that person now comes back and needs their second dose, how do we then link it to that person to say, okay, we registered you under ABC 123, and now like that we know that you're getting second dose and not first dose, and is this the right time between when you got your first dose and second dose? So, people would get their paper to say, I got it, but like that's still relying on people to have that piece of paper to say, this is when I got the first one. Is this the right time for me to get the second one? We know a lot of people like that their lives are very busy and complicated. And so, hanging on to that piece of paper is not necessarily the easiest thing to do. How do they keep that record so that they can show eventually, what if they wanted to travel somewhere later, that like, yes, I've had my 2 doses. So if I wanted to fly back home to my country, like, or go somewhere that might show that need that, like how do they have that accessible record so that they can show that, yes, I have gotten my 2 doses and I am fully vaccinated. So, I think these are really like some of the very basic logistical challenges. One of the other populations we're really dealing with in the same way is the shelter population. So people who are underhoused or homeless and having the same kind of issues of transiency. And so, they're doing a lot of clinics within the shelters and trying to get people as we can to come and get that vaccine. But the challenge with the 2-dose series is that second dose, and how do we, catch you when you're available? We know a lot of people have side effects with the first dose and sometimes with the second dose as well. And so, like being worried, but we also know people can get infected around that same time of the first dose. So some people might have some symptoms, and like, how do we make sure we get them testing to make sure is it vaccine related, or maybe you do actually have COVID. So making sure we're kind of putting the supports in place that people would have to get vaccinated as well, and not be worried about, am I actually sick with something else afterwards. So I think that those are, some of the really real logistical challenges that we're having to make sure we have. And I think this is really where, like, thinking about how we're going to use the vaccine information going forward, because obviously a lot of people are asking, like, okay, like, what's our cover? We're still seeing outbreaks in shelters, populations. What can we be doing more? But if we don't even know how many people in that setting we've vaccinated, it can be really hard to kind of rally the resources around it, because we don't really have the denominator of people. Like, it's a very, is how many people are actually using the service and how many people have been vaccinated who are using it. So I think, again, it has to go back to like that, really working with that local community, like having the people we could trust to help mobilize and bring people in, and being really creative as to help support people in these situations so that they can still have access to vaccine.
That's super interesting. And I think it highlights really, like, even vaccine is over, there's the post-COVID issues of figuring out, like, how do you maintain record of people and how do they obtain, access to travel like other people who have taken the 2 doses, but have record of that links to their identity. So I think this is a really, interesting and big challenge, I think, onward. And I think also one of the things I have seen in the shelter communities is, like, it's exactly that, like, a lot of what happens in shelter communities has also linked to mental illness, substance abuse. And so sometimes the intersection with that is about having someone in the shelter communities that the people trust to kind of go back and get their second dose and first dose. So it really highlights lots of opportunities to kind of like engaging in public outreach and helping there. That's great. So maybe, Gabriela, I'll turn on to you. And I think we are interested to understand, I know we talked about vaccine compliance, but also there's anti-vaxxers and vaccine hesitancy, and people, have hesitancy, not compliance towards the vaccine, but hesitancy towards the effectiveness of the vaccine, the side effects of the vaccine. So in that terms, like, how does the phenomenon of COVID-19 vaccine hesitancy, first of all, like, spreads within communities? And is it similar to other communicable diseases such as HIV or other pandemics?
Yeah, that's actually a great question, because what we're seeing right now is very interesting. There's, of course, the people who oppose all sorts of vaccinations, and with them, the strategy has to be other, and they still oppose this one as they did others. So that hasn't changed. But one new aspect that we're seeing is people who are not normally vaccine hesitant, who have their immunizations up to date, but there are new concerns that we hadn't seen before. So while, for example, one key aspect of vaccine hesitancy is vaccine safety, that now is combined with these ideas that the vaccine was rushed. How do we know it's actually safe? We don't have long-term studies of what's going to happen. So there's a lot of anxieties in people who normally are not anxious about vaccines. And that is a challenge, of course, for public health communication in addressing these COVID-specific concerns, right? That may be pushing people towards hesitancy and not really getting it. Right now, what we're seeing is a lot of hesitancy regarding, I got AstraZeneca, and now there's so much conflicting information. The National Advisory Committee came out with this language of preferable vaccines, and that caused a lot of confusion. So that's the type of hesitancy we're seeing now. On the other hand, what we're seeing in our focus groups is that people who regularly, for example, they're not necessarily vaccine or anti-vaccine, but they wouldn't get their flu shot every year. They kind of, or, boosters every once in a while, every few years you have to get your tetanus booster or whatnot. They don't do it. They kind of underestimate the risks and they think, I don't have time, this complacency. Or they simply don't have the time to do it. And these people are now really anxious to get their vaccine. So the opposite is like they really understand the risk of COVID-19 as being greater than tetanus or the flu. And whereas other years they've been more kind of complacent or even not getting it, they're getting their flu shot because they say, well, this is the year I don't want to get the flu on top of COVID, right? So they're starting to get up to date in their immunizations because of this. So there's interesting shifts coming and going in vaccine hesitancy right now that are risk communication that I think should be addressed.
I think this is super interesting because I think the challenge in many communities and in public in general is not everyone is tuned to the science of looking and digging into the right information, but what is being perpetuated on social media and what's being perpetuated on general talks within communities kind of get disseminated, and then it's like the social effect or the ripple effect where it kind of transmits. And so it speaks to kind of like, I think one of the most insights to us as students is we recognize that, like, how do you communicate science is really important, because if it's communicated in a wrong way, it can completely have the opposite effect. So on that note, I would like to shift to you, Mohan, to kind of ask like, what do you think should be done more in terms of like the communities you described to help support, more compliance with vaccine, and also like inequities that have impacted people during the COVID period? So we know like they had rough work environments and all that. What are things that we should consider as we think of recovery and post-COVID trajectory? Oh, I think you're muted.
Sorry. So I think all of the factors, the social determinant factors, play an important role with COVID-19 as well. All right. So it's about creating access to income supports, creating access to food security. Those are really important for people. But I think to get people over either they are complacent or they are hesitant, I think the most important thing that we need to do is adopt a hyper-local, culturally competent community engagement strategy, right? So when I say hyper-local, you need to ensure that you are all of your health promotion and community engagement activity is culturally competent in the sense that we have information in local languages. Right? So if you take the top 3 languages other than English is Bangla or Bengali, is Urdu, and is also to some extent Tamil and Pashto and Dari. So making sure that all of the information that is being made available is being made available in these languages. Using local residents. to promote that information, using local community leaders, like engaging the main mosque people in the mosque, ensuring that the imam in the mosque is communicating information, is sharing this information, and also most importantly, doing door-to-door campaigns. Because these are high-rise buildings, it's a lot easier to do door-to-door. So we were able to do that. So that I think is really important in terms of helping people understand the importance of getting vaccinated, but also reassuring them throughout the process that there are supports available to them. Right? And I think this has worked reasonably well for us, because if you look at the COVAX data, as of today, I was just checking the COVAX data. It's become a habit to check that. So I was checking the COVAX data today, and I could see that the city's complete vaccination rate, which is first dose and second dose, is the city average is 25.7%. Tennessee is at 21.2%. So we are really close to the city average. So to say that there is a lot of vaccine hesitancy or even complacency for that matter in that neighborhood is really not true. But I think that's because of many reasons, and what holds true for one community or one neighborhood might not be the same for another neighborhood, right? So we need to take a very local strategy based on that neighborhood.
So that's truly important, and I think one of the important takeaways here is to really not assume and have assumptions about hesitancy, but more to look into the micro communities within the bigger communities of Toronto to kind of understand exactly what are the patterns and uptake in vaccines before we kind of like make kind of like findings or claims about what is the patterns. I would like to take now, being mindful of time, some of the questions, and I will have a couple of clinical questions. So I'm gonna direct them to you, Michelle, but then all of the other panelists, Gabriela, Mohan, you're very welcome to pitch in. So I think the first question we have is, are the vaccines interchangeable, and why has this only been determined in recent weeks?
Yeah, so it's actually always been there. It's just probably been a little bit more of a buried component to the National Advisory Committee Immunization Statement, where, like, you know, if the product's not available, like the preference had been completing the dose, because we know that the clinical trials that we have information on were based on the same dose. So kind of keeping to the evidence that would come out of the clinical trials would be, if you got Pfizer, and that's sort of what we would be able to say is sort of the best safety and efficacy. But it always had the caveat there that, you know, like if you can't complete it with that dose, then you could use another product to do that. I think it's just come a little bit more to a head of needing to make it a bit more of an explicit statement and recommendation about the interchangeability, given the supply that we've had in Canada. Because we've had a very fluctuating supply between Pfizer and Moderna, then like we knew we were going to be in a situation where many more people may not have been able to get the same product as their first shot as their second shot. So the goal of the committee was to say, you know, like, how do we make this more explicit to kind of reassure people, yes, it's fine, because before it was just kind of a buried line in the recommendation to say you could do this, but to more explicitly say that, like, to reassure people, yes, like this is fine, this is safe. You know, the vaccine platforms between those products are very similar, and we don't have any concerns about, you know, if you got Pfizer first and Moderna second, that's fine. The other reason, obviously, that this was kind of came to a head was because of the changes around AstraZeneca. So many people who would have gotten their first dose of AstraZeneca, you know, now with the new information that was coming around some of the risks associated in terms of vaccine-induced thrombocytopenia and thrombosis syndromes, that you know, that we were now preferentially recommending that people would get a different product, so one of the mRNA vaccines with the second one. So again, sort of really wanting to be clear that's fine to do. I mean, all of the products have the same core element in terms of the backbone of what the immune response is meant to be. So they're all sort of stimulating that same aspect of the virus, so that people have that immune response to the key kind of part of the virus that presents itself. So the main difference is that platform, but really I think needing to be explicit to say, yes, if you got AstraZeneca first, it's fine to get an mRNA second, and as well, you know, more confidence in that statement now, because we had additional data from other countries where they have been using this mixed dose. So particularly from the UK, we had a lot more data in terms of their how their experience has gone in using that mixed schedule AstraZeneca first, as well as some of the clinical trials that they've done. So we knew, we do know it is more what we call immunogenic. So people do get more local side effects when they have that mixed schedule. So if you got Zeneca first and a Pfizer Moderna second, we know that your chance for like kind of a local not feeling well, swollen arm might be higher than if you got like the same one. So we do know that that's risk, but we also now have more information about this, that's still within, like, definitely within the realm of safety. We're not seeing any sort of serious side effects associated with that. It's really just like local transient kind of systemic, those kinds of reactions. And as well, like we actually, had some data to say, could it even be better? So some of the early data around immunogenicity to say that if you got Zeneca first and one of the mRNA second, some people were actually been showing a better immune response than if you got Zeneca. So I think that, that interchangeability, but also the reassurance that, like, yes, this may not be what you were thinking you were going to get when you got your first dose, but that this is still effective for you and safe for you to get.
This is very important. Thanks so much. A similar question, I think that we can address it, is related to AstraZeneca, since we're on the same topic, is it says many people felt unease with the reports of AstraZeneca being associated with higher chances of blood clots, and thus started wondering if there were similar risks with Pfizer and Moderna vaccines. How can we regain the public's trust with science that is continuously changing, especially when public advice is subject to constant change as well?
Yeah, I think that's a really excellent question. And certainly we know the rapidity of which information is coming is just an unprecedented time. So like nobody is used to getting this amount of information at this rapid pace. So, we know it's hard for the public, it's hard for the scientists, it's hard for the clinicians. Family doctors are confused. They're getting new information all the time. It's hard for everybody to keep up. So I completely understand, the unease that people feel, because it is so much to take in and it feels like a lot at once. I think that it was a very specific reaction that we were seeing with the data. And I think that the Zeneca, some of the early questions we had, like, is it just AstraZeneca? Is it COVID-19 and AstraZeneca? Is it Johnson & Johnson and similar to AstraZeneca? Because they are all using the same platform of vaccine, which is very different platform than the mRNA vaccine, so the Pfizer and Moderna. We also had a lot, like Pfizer and Moderna were out of the gate a lot faster than Zeneca. So we do have a lot more global data in terms of the safety of Pfizer and Moderna internationally earlier than when we had AstraZeneca. So I think we had, fairly good confidence that we were not seeing that same signal in terms of these kinds of thrombosis events with the Pfizer and Moderna that we were seeing, starting to see with AstraZeneca. So, I think there's different countries that went different ways. Like, I think we still haven't sort of seen, because Johnson & Johnson hasn't been the same uptake of vaccine, and we aren't even using it in Canada, then it's hard for us to say, is this really just AstraZeneca? Or like, could we still see the same results with Johnson & Johnson? I don't know if we fully know that. We haven't seen as much, like the US has hardly used Johnson & Johnson, so potentially there is still a class effect associated with it. We know as well, it was hard to say, like the second dose ones, we weren't seeing the same impact of this kind of thrombosis with the second dose of AstraZeneca as the first dose. But again, there too, like, if you didn't get the same reaction with the first one, it's probably less likely that you would get it again with the second one. And people who had that reaction obviously didn't get AstraZeneca again. So there is a very, evolving science that we need to have, and that we're, being able to follow people for long enough and get that good information. What I think has been really remarkable through this pandemic, though, is just the free sharing of information. So, all countries really stepping up, coming forward, sharing whatever they have with everyone else in the global community to be able to say, this is what we're seeing. Are you seeing the same thing? What kind of cases are you seeing? And so being able to really leverage the experience of countries, like every country is like, someone will have to go first, right? So like, who's seeing that first? What we are seeing with the mRNA signal that we came out of Israel is as a myocarditis concern. So because they've given out so much of the Pfizer in Israel, and as well, like they started the earliest with the young population, they were kind of the first to see that some younger individuals, probably like in the 16 to 25-year-old age group, especially boy, like men, were getting this heart inflammation syndrome. So it didn't seem that severe. Very few of them had to go to hospital. It kind of was a more mild, like high good recovery from this event. But again, it was only likely to be seen in Israel just because they were so much further ahead in delivering that vaccine. But they rapidly shared that with all the other countries. So now we're on much higher alert for this syndrome because we are looking for it, and we are starting to vaccinate the 12 to 17-year-old population as well. So we do know that we've had some similar events in Canada, but not to the level we're seeing at some of the other parts of the world. But I think that the takeaway of this is that there's a very high and alert system that's looking for these kinds of things. As soon as we hear about any case, those are reported locally, they're reported provincially, they're reported nationally, they're reported internationally, so we can share and make sure that any potential thing that could go wrong, that we're monitoring for that and assessing it to say, could it be related to the vaccine? Is this something we need to be worried about? Is anybody else seeing this? Why is this happening? To be able to then make recommendations as soon as possible.
Wonderful. Actually, and you brought the comment about the myocarditis, which is exactly a question we had in the chat. So you addressed the question. And it's really interesting. And I think the global pattern of each country sharing is something that the whole world is kind of learning from each other, is a new phenomenon that we're witnessing in COVID-19 as a pandemic, as a global pandemic. Gabriela and Mohan, I would like to get your input on first, how do we regain Gabriela, how do we gain public's trust when, there's a lot of changes in what's being communicated in media about the effectiveness of vaccine, and people are starting to be more on the hesitant side? How do we shift people to, to come back to the facts?
Yeah, this is part of the research we're doing now in an environment of so much uncertainty, scientific uncertainty being covered by the news 24/7. How do we gain public trust? And that is key in any sort of pandemic response. And we have recently conducted this study and found that some of the ways to really get the public to trust the message, because it doesn't matter how well crafted the message is, it all comes down to who is talking. So the spokesperson is really crucial in this context. So we found that, for example, beyond consistency and everything else that the message should have, people during the pandemic are accepting and receiving better, and even feeling that the same message is more trustworthy and is way more persuasive if the person who's talking is, for example, an expert versus an elected official, a politician. Something that we've seen in Ontario. By the way, I'm in Ottawa, even though I'm in Manitoba, I'm in Ottawa. Because that we see in Ontario is that many times when the premier giving the information, the reception is not the same, and there's more of a rejection to it, or not as wide acceptance, because he's perceived as a politician, of course. Whereas something that we see in BC is that Dr. Bonnie Henry she really anchors the message to the people, because she's perceived as, she's a doctor, she knows what she's talking about, and so on. In the case of smaller immigrant communities, it's important to have someone who is trustworthy, like Mohan was saying, either the man or someone that is a community leader. That is key. Now, the other important aspect is to accept, openly, that yes, there are uncertainties and the science is going to change, and inevitably the guidelines are going to change, and it's okay to feel anxious about it, but always go with the evidence. And that is something that we also use a lot as a recommendation for dispelling myths and all sorts of misinformation about vaccines. For example, when we were talking about AstraZeneca and the clots, it's bringing the risks into perspective. What's the risk of, clots due to AstraZeneca versus clots because of COVID-19 infection? So that puts things into context a little bit more. So I would say those are the key things: the spokesperson, and also putting into context the risk.
Mohan, would you
Yeah.
like to add?
Yep. So I echo everything that Dr. Gabriela mentioned here. So like I said, keep it local and use community leaders like the imam and the local family health practitioner who's been practicing in that community for 20 years. He's a known face. He knows every child, every mother there. So that familiarity, and also they see them as a person of authority when it comes to health. And having that person share that message is really important. One other thing that we also did was we have done so far 4 pop-up clinics in the Crescent Town elementary school there. So we have asked the principal to be there around when the clinics were happening, because he is again seen as a person of authority, and being there during the vaccination as part of the vaccine effort and the clinic that was being organized there, and seeing him there also gave a lot of comfort to people, because that's a person they see as a person of authority, the person they can trust, and that person being involved in that activity there meant that this is an activity that they could trust, right? But one thing that we are not doing as much probably is, and I would probably say this is more, probably the media should take it over, or maybe the province should do more of this, is talk about successes. Whenever the positivity rate went high, whenever the number of COVID cases was really in the thousands, we spoke so much about it. That of course, bad news sells more than good news. We know that, but I think in this time it's more important to talk about good news. So I think yesterday's total case count in Ontario was 255 or something. So let's talk more about that. We talked a lot about when it was 4,900. Everybody was talking about it. Why is not everybody talking about 255 cases now? Right? So it's also important to talk about the successes that we have achieved over the last 4 months. Another example is today we heard that the province is 1 month ahead in terms of its vaccination target. I mean, that's a huge success, right? So we should be probably also talking about success and good news while we are sharing information about bad news and the pandemic and all of that. I think that's also important.
I think that's an excellent point, is we often lose the balance between good and bad. It's a human being tendency to look at the missing portion of the cup and not at the rest of the cup. And I think it's very important to kind of like recognize that I mean, like all of the challenges we have faced, but that, like the government response, the public health response has been effective elsewhere. We would not have seen, that higher second doses and first doses. Like there has been a lot of going on, but initially when the criticism was kind of like crippling within communities, but now the positive and the wonderful, like the strong work that has been on the ground is not as much emphasized. So it's really important to really know that. I'm mindful of time. I would like to wrap up this event by giving each of you a minute to kind of say an advice to us as students as we think of how we contribute to science communication and think of, like being engaged in community. What should we consider? Michelle, would you like to start?
Sure. I know. Thanks for the discussion. I think some really, really good questions in the chat, so we can get to all of them. I did see one about like family members, and I think that that's something that we can all do, because we are, like you guys are specialists and scientists and people in science programs. People will look to you as being leaders and communicators, and even if that's just in your own family and friends, being a really respected voice and speaking clearly about the evidence, being able to point people to credible sources of information is really important. Not amplifying bad information or feeding into some of the misperceptions that are out there, and like really addressing it, and not being afraid to have those hard conversations of people who might be saying, either like really sort of out there things or even like real things and worries, but like I think recognizing, acknowledging people's anxiety and concern about it, but really being able to point them to those credible resources, encouraging them to talk to their healthcare provider, encouraging them to talk to their local leaders to get more information, and good information is something that we can all be doing within our own communities.
Wonderful, thank you. Gabriela?
Yes, I agree with what Michelle was saying, and I think it also is very important the aspect of listening. And sometimes I think that scientists and physicians in particular kind of miss that aspect.
Mhm.
People come with concerns and they need to be heard. If we're going to dispel doubts, it's important to first know where the concern exactly lies, validate the person, tell them it's natural to be concerned, and validate them. Like many times, especially with the anti-vaccination debate, we see a lot of aggressive responses to people who are vaccine hesitant, and that is actually counterproductive. So validating them, telling them it's okay to have concerns, and then giving them or directing them to the proper information
Mhm.
sources, it's really important.
And last but not least, Mohan.
Sure. So as tomorrow's leaders, my request to you is that always apply a anti-oppression equity lens to any problem that you're trying to solve, whether it's a health situation like this or whether it's a social condition or a social problem that you're tackling. Try to use an anti-oppression equity lens is really important. For example, here, there is a difference between how people in visible minority communities are branded as vaccine hesitant, while people in mainstream communities like Caucasians it is more branded as anti-vaxxers. One is based on is based on ignorance, while the other is like more of an informed political choice. And there itself, the narration of how these two groups are being branded, I think there is a problem, right? So always take an anti-oppressive equity lens to any health or social problems that you're trying to resolve. And I'm sure that as leaders, as tomorrow's leaders, you guys will do a great job, better than what we do.
I would like to end by really thanking three of you for joining us. It has really been an honor, and we really appreciate taking time off your busy calendars to come and talk with us. And I personally learned a lot, and I think everyone learned a lot, and we will be sharing the recording with people to learn more about the important points we really discussed. Really want to thank you so much. We really can't thank you enough for your time and generous inputs and, like, thoughtfulness. Thank you so much.